Grateful for the opportunity to be here with you for a few minutes to talk about some of the work that HealthInsight has been doing around health information technology and using technology as a tool to support care management in our communities. So just a little bit about HealthInsight to get started here and to help you know who we are. HealthInsight is a nonprofit organization that's operating in Utah, Nevada, and New Mexico. We're actually a series of 3 state-based community collaboratives, multi-stakeholder collaboratives. We work together on a number of issues, but we each have local governance and are owned by our communities in a very real way. We've been doing work for a long time in those communities across a number of projects in transparency, health information technology, payment reform, human factors science research. We have a lot of quality improvement activities associated with quality assurance work for Medicare that we've been an innovator in. Our organization has a lot of hats, and we do that intentionally. I'm going to talk a little bit about that in a minute, but we're a Medicare QIO in all 3 of those states. We're a regional extension center for the Office of the National Coordinator. We are a beacon community in the Salt Lake area. We're CVEs, we're running an ATOP project for CMMI. We're New Mexico and AF4Q, and it goes on and on. You get the idea. So we have lots of acronyms too, and that's part of our world. Our reason for existing organizationally, we focus into 5 areas that we call ends policies, what we're trying to accomplish as an organization. And so we have a very real focus in engaging patients and public, improving the health of the population as a whole, which has been very challenging for us organizationally to get beyond health care alone. We try to improve the processes and outcomes of the healthcare system. We're trying to affect the use of resources and make that a more responsible use. And we want to see a system that's transparent. This slide's really about showing how those connect to the triple aim and to the national quality strategy and other federal agendas. We see ourselves as a local nexus, a connector of people. We work to build will in our community, and we work to bring programs together because we think that can accelerate pace and avoid a lot of the confusion that exists in our local market otherwise. Organizationally, we've worked on a number of health information technology projects that support care coordination. I'm going to talk about a few of those, but I want to mention them all here. The Regional Extension Center activity for health information technology adoption and meaningful use, and particularly focused on small primary care practices. Quality improvement organization activities, particularly related to physician office and care transitions work. Beacon Community Program efforts to impact health information technology. We've been involved in developing and or supporting health information exchanges in each of our communities. And then the ATOP project, which is an activity focused on preventing unnecessary hospitalizations in nursing home residents, which is a new project we're just beginning. Within the REC program, we've done a lot of work in that space to build out the health information technology infrastructure in our communities, and we're beginning to see the benefits of that. Through the REC, we're able to, we think, and through that technology, drive demand for better coordination and sharing of data in the community by bringing more providers to the table where they really want that kind of data in their practices because they have tools to manage and use it. We've seen that under the REC that practices are much more quickly able to adopt and use technology, and these practices need help. These are the smaller practices. They're not supported by the large systems, and without help they're not moving along. But with the help of the REC, we've seen an additional more than 300 practices who didn't have a regional extension center, or didn't have an electronic health record in our community have adopted them, and more than 1,000 providers in our community who are now able to have attested and met the initial meaningful use requirements. In the QIO program, we've been working on a couple of projects that I think are important to the area of care coordination. We've been helping providers in our states report data, the PQRS data, directly to CMS, either directly out of their electronic health record or using a vendor who's helping them extract that data from their electronic health record. This is challenging initially. It's a very important activity for providers to be able to automate that process, to not have it become a manual process forever, because that kind of data going to CMS is expensive to do. It's not sustainable unless we automate it. And so the QIO program has made a considerable investment, and in our communities we've got more than almost 150 providers who are engaged in that process of extracting data that way. And we've also been working with more than 100 practices on a cardiovascular care coordination project using decision support tools from their electronic health records to manage their patients with heart disease and to improve their workflows and their outcomes as a result. Many of you know about the Beacon Community Initiative funded by the Office of the National Coordinator. We see our Beacon community, which is in the Salt Lake Metropolitan Statistical Area, as an innovation test bed. It's a place where we tried out a lot of things about ways to bring technology to bear to solve problems. And there are dozens of experiments we've conducted, but a couple here, hotspotting, and I'll show you some data about that, where we've supported clinics in doing care management and identifying which patients in their practice are most likely, using their tools, are most likely to benefit from care management, and shown the benefit that produces for them. We've also done electronic pulse work to be able to bring end-of-life care wishes and desires of patients and put them in front of providers at the right moment in moments of care decisions, so that can be an automated process and we can improve those end-of-life decisions. We're also, through this project, generally deepening the level of connectedness in our community. It turns out this is a much more complicated undertaking than we thought it would be when we started 3 years ago. In Salt Lake, we thought we were pretty advanced, and by the metric that CMS was using, the rate of adoption, we were quite advanced, but we're not all the way there, and we're still working on that. And then we've supported HIT-enabled clinics in diabetes care management. And so I want to just talk a little bit about those results. In the Beacon Community Initiative, we used to be focused on just measuring testing for A1C or measuring the screening for diabetes in the community. But with the use of electronic health records, we've been able to match and watch the improvement over time in at least the intermediate outcome of control of diabetes. And so we've seen in that subset of our population a substantial number of additional people whose diabetes is in control. And that's a direct result of the care management tools in place in these electronic health records made possible through the EHR. And we've also seen another phenomenon in our communities where the independent clinics have made substantial gains to be able to catch up to the large systems that have more systems in place earlier and more resources to devote to management of their populations. You're not necessarily supposed to see these, but this is the result of a pilot we did with a few, this is a single clinic site working to help them hotspot where their potential patients are that they could make the most gains with by providing direct care management support. And under this pilot, you can see substantial gains in A1C control, blood pressure control, nephropathy testing, reduction in ER visits over time in that population as a result of a targeted care management initiative. The last project I want to just mention that we're engaged in and starting to see is this ATOP project, again focused on nursing home patients. Through this project, we'll be using an electronic registry to help us track nursing home patients in the long-stay residents in these 25 nursing homes, and implement a clinical intervention protocol with clinical staff added to the nursing homes to help them better manage patients early and prevent unnecessary hospitalizations. Our expectation is we'll be able to reduce those unnecessary hospitalizations by as much as 2/3 within that 3-year period. That's funded by CMMI. So my key lessons for you in relation to health information technology in our communities would fall into a couple of categories. HIT infrastructure is a very difficult thing to build out in communities. There's political issues, there are environmental issues in every community, and building the capacity to connect all of those parts is hard spade work. It doesn't happen easily. And we've learned that in a lot of ways over the last few years. The tools that we need to do that are not yet mature. The electronic health records are, even the best of them are not ideally suited to the task, and they're evolving and still need to evolve further. And workflow for these providers really has to change in a fundamental way. And so we've to some extent been sold the bill of goods that workflow doesn't have to change, that some of the vendors are suggesting that they can do this without that, and we've found that just doesn't work. If you're not willing to change how you operate, you're not going to be able to operate effectively with an electronic health record and do care management in an effective way. We think critically that the many programs that are out there have to be coordinated and connected to be effective. Organizationally, we've tried to do that. We've taken it as a core charge of our activity to bring together all of these different HIT-related initiatives and try to make sense of them in our community. But even in our case, it's frustrating and difficult for providers to connect the dots. And in communities where those activities are less connected, it's even more frustrating and more difficult. The last message I'd say for policymakers is there's a lot of pushback around HIT in the latest rounds of policy debate about ways in which it's not working or ways in which meaningful use and those kinds of projects are not helping. Our view is we need to see this, and we need to see it with a long view. This was not a transition that was going to happen overnight in a year or 2 or 3. But if we look at where we are today, we're a lot closer, and if we can stay that course and continue to push forward on that policy level over the next few years, we think we'll see significant improvement across the nation. So, thank you.